Hello guys and welcome back to Count to 10. My name is Ani and on today's podcast we're going to be covering regional circulation. Now this is the fourth installment of our cardiovascular physiology topic, and as per Mac 95 this actually has the most number of LOs attached to it. Now we won't be going through all the learning objectives mentioned in Mac 95, but focusing specifically on the ones related to cardiovascular physiology. There's a lot of overlap when it comes to regional circulation with topics such as neurophysiology, maternal and fetal physiology, and GIT physiology, but we'll leave that for later date. When preparing for this podcast, I was going through my past notes, and I was actually really surprised to see that this was actually one of the topics where I wrote the most amount of notes compared to any other cardiovascular physiology topic. Now, in saying that, I don't think you have to know this topic as in depth as the other topics we've already covered. There is a lot of nerdy principles that come up with regional circulation, and I will go through that just to make sure we cover all the bases. And I really shouldn't be saying this as someone who wants you to listen to this podcast in full, but this is one topic where you could skip to the SAQs to get the best bang for buck if you're time poor. So for this pod, I've specifically chosen the learning objectives that I think best relate to cardiovascular physiology, and with that said, let's dive straight into it.
1, 2, 3, 4.
The first learning objective we're going to cover today is discuss the control of blood pressure and the distribution of blood volume and flow throughout the CVS, including the factors determining systolic blood pressure and the regulation and control, total peripheral vascular resistance and the factors affecting it, the relationship between organ blood flow, demand, and the role of autoregulation, clinically significant features of coronary, cerebral, skin, muscle, renal, hepatic, and splanchnic circulation, and then finally, the essential features of the microcirculation, including fluid exchange and its control. Now, this is obviously a huge learning objective, and we're not going to cover all the points in detail. What I want to convey is understanding what do they mean by control of blood pressure and the factors that govern blood pressure. So to start, for me, the factors that govern blood pressure can be divided into two simple categories. First, how does systemic circulation work? And secondly, what are the physics governing blood flow? With regards to systemic circulation, we all know this refers to how the blood ejects out of the left ventricle into the arterial system, followed by the capillary system and then the venous system, returning eventually to the right side of the heart. We've already looked at the role of the heart in our previous podcast, so today we're going to focus on what is the difference between the arterial, capillary, and venous system. We can classify differences between these three systems in multiple ways. We can do it by their morphological makeup of the vessel walls. We can do it by comparing flow rates and cross-sectional areas. Or we can also do it by looking at the role of each one of these systems. So firstly, to understand vessel morphology, we have to know what vessel walls are made of. Each vessel has three functional characteristic layers. The first layer is the intima, so this is made up of sheets of endothelial cells. The second layer is the media. This is where the smooth muscle lies, and it's embedded in the matrix full of collagen and elastin. And then finally, you have the adventitia. This is the outer inelastic material, which is connected to the connective tissue. Now, the arterial system has to deal with a high amount of pressure coming out of the left ventricle. Not only does it have to deal with a high amount of pressure, it needs to be able to convert that pulsatile pressure delivered in systole and make it into a constant non-pulsatile flow. The way it does this is by within its vessel wall characteristics, it has a high amount of smooth muscle to be able to deal with a change in resistance, as well as a high amount of elastic tissue to be able to store that energy and convert it into elastic energy. Typically, the cross-sectional areas of the arterial system are the smallest. So an example being in the aorta, this is 4 centimeters squared. The pressures within the arterial system are the highest, and accordingly, the flow rates within the arterial system of blood is also the highest, reported to be as high as 20 centimeters per second in the aorta. The fact that the arterial system has a high amount of smooth muscle is also really important when it comes down to the arterioles. These are the gateways before you get to the capillaries. So here, you need a huge pressure drop before you get into the capillary system. And to achieve this, you need a lot of smooth muscle, which is autoregulated by the autonomic nervous system to either control its diameter to vasodilate or vasoconstrict accordingly to the pressure before and after it. This is because when you get to the capillary system, it has a huge cross-sectional area of approximately 2,800 centimeters squared. The goal of the capillary system is to allow the exchange of O2, CO2, nutrients, and waste, and therefore the flow in the capillary system has to be the slowest to allow diffusion to occur. Accordingly, the flow is reported to be the lowest at 0.5 millimeters per second. In comparison, the arterial flow was 20 centimeters per second. The other unique thing of the capillary system is that it doesn't need those extra vessel wall characteristics such as the media or the adventitia. It only needs the intima and mainly the endothelium. The endothelium is a very unique component, and it's the only structure that lines the whole cardiovascular system. Within the capillary system, the role here is to provide the thinnest layer so the diffusion can occur most efficiently. However, the endothelium also has additional roles within the arterial and the venous system. This is because the endothelium can produce autoregulation factors itself, like nitric oxide, prostacyclin, and endothelins. It has antithrombotic properties by its ability to produce tissue factor, thrombomodulin, heparin, and tissue plasminogen activators. It has angiogenesis properties through production of vascular growth factors, which can help to repair and restore the endothelial layer. And all of these properties actually have an important clinical implication. Prostacyclins via the COX-1 pathway inhibit platelet aggregation. Nitric oxide helps to promote vasodilation, and endothelians are potent vasoconstrictors. Knowing these three factors, we can actually target drugs that help to give us clinical effects. An example being endothelin receptor antagonists, such as those used in pulmonary hypertension like bosentan, can help to promote vasodilation. Drugs like GTN and SNP utilize the nitric oxide properties to help produce vasodilation when treating hypertension. So the endothelium is actually a very important layer when it comes to the vessel wall characteristics across the arterial, capillary, and venous systems. Now going back and completing the differences between the arterial, capillary, and venous system, now when we look at the venous system, we can say that the role of the venous system is to allow large capacitance of blood volume where the flow rate isn't as high and the pressures aren't as high as the arterial system. So here, you can have a lot more elastance, but not as much smooth muscle, because the pressures in the venous system range from anywhere to 0 to 20 millimeters of mercury. The flow rates are lower than what you see in the arterial system, roughly 10 to 12 centimeters per second. And while you don't have too much smooth muscle, you still have some being able to be controlled by the autonomic nervous system that can help to regulate venotone. And as we spoke about in the last podcast, this can modify venous return and impact cardiac output. Now that we know how to describe the systemic circulation and how that works, we can now look at the physics governing blood flow. The main principle that helps us understand the relationship between pressure, flow, and resistance is going back to Ohm's law, in which we can say that flow is equal to the change in voltage over the resistance. And if we substitute voltage for pressure, we can say that flow is equal to the change in pressure divided by the resistance. That is the fundamental principle understanding blood flow mechanics, and it's usually the first line you write in any SAQ relating to regional circulation. Now to take our knowledge a step further, we can apply a second law that we've already discussed previously, known as Purcell's law, to describe the relationship between pressure and flow. Purcell's equation states that flow is equal to pi times the change in pressure times the radius to the power of 4 divided by 8 times the viscosity times the length. Typically, this equation is rearranged to equal resistance, where the denominator becomes the numerator and the numerator becomes the denominator. The important caveat to this equation is that originally Purcell said that this equation can be used if three characteristics are met. First, this law is only for steady flow, i.e. non-pulsatile. Secondly, it's only to be used for laminar flow. And thirdly, it's only to be used where the fluid in the flow is considered to be Newtonian. Now, interestingly enough, blood does not meet any of these three criteria. Blood flow is not steady, it can be turbulent in some regions, and blood is not considered to be Newtonian. Newtonian fluids are those that don't change their viscosity with the changing in flow rate. So the classic example being water. If water's flow rate increases or decreases, the viscosity of water stays the same. Now, why is this concept so important with blood? Well, it relates to two further terms associated with viscosity. The first term is called shear rate, and the second term is called shear stress. The basic way to understand shear stress is that think of it as the frictional force generated by blood flow in the endothelium, while shear rate is the speed of the blood flow itself. When you have a high shear stress, this is generally when you have a high flow rate. This tends to pull the lining off the endothelium, causing damage, and this property is called viscous drag. Essentially, this is what happens as we normally age. In conditions such as hypertension, you get a high amount of viscous drag, and this is the reason why you get tears within the arterial wall, causing aneurysms and dissections. On the flip side, shear rate also has some significant clinical consequences. When you get a high shear rate, the viscosity of blood decreases, and this is called shear thinning. When you get a low shear rate, this is when blood may aggregate and form clots. So take a condition such as polycythemia, where you already have such a high resistance because of the high density of blood within the circulating system. If you decrease the shear rate, now you're getting increased resistance and therefore increasing work of the circulating system. Not only is this causing knock-on effects to increase oxygen consumption, but it's increasing the chance of precipitating conditions such as clots developing or microaggregates forming within the circulating system. So then the logical question to be asked is, if blood flow does not meet these three caveats used in Purcell's law, why do we still use this equation to describe flow within the circulating system? And this is because there's a few compensatory systems within our body that make blood fit these three semi-caveats. The first is how blood flow can be converted from a pulsatile flow into a non-pulsatile flow in a process called hydraulic filtering. This process is actually really important because it helps to decrease cardiac workload and in turn optimize myocardial oxygen supply and decrease its demand. The main way this is done is by utilization of an effect called Wynne-Kessel effect. The Wynne-Kessel effect describes how when blood is pumped out of the left ventricle and ejected into the aorta, the kinetic energy of blood flow is stored and then released during diastole to allow continuous blood flow throughout the cardiac cycle. The reason this can be achieved goes back to the characteristics of the aortic wall. This is a high elastic, high smooth muscle blood vessel. During systole, the elastic wall stretches and stores this energy as potential energy. When diastole occurs and the aortic valve is closed, the stretched walls then contract and that stored potential energy is converted back into kinetic energy. This is what generates your diastolic blood pressure and is the main reason how we convert intermittent left ventricular outflow to continuous blood flow. When we say Wynne-Kessel effect, this is what we're describing. It's the conversion of intermittent LV flow into continuous blood flow. The second role of the Wynne-Kessel effect is to decrease that cardiac workload that we spoke about earlier. Now, this Wynne-Kessel effect is dependent on three main factors. The first main factor is the elasticity of the aorta and the arteries. This naturally decreases with age, and therefore we get the loss of the Wynne-Kessel effect as we get older. Subsequently, clinically, what you see when you anaesthetize elderly patients is large swings in blood pressure from high systolics to low systolics with any small change in vascular resistance. The second factor this is dependent on is the presence of peripheral resistance. When we decrease total peripheral resistance, we decrease the amount of blood that's stored in the aorta, because there's no backflow pressure storing more blood in the aorta and the large vessels. Therefore, less constant blood flow is delivered to the peripheries. The third factor needed for the Windkessel effect is a functioning aortic valve. If you have aortic regurgitation, now that large amount of blood that's stored in the arteries flows back into the heart, decreasing the amount of stored energy you have for the start of diastole. Therefore, going back to the Purcell's law, this is the first way where we can negate the first caveat of requiring non-pulsatile flow. The second caveat of requiring laminar flow is achieved by the use of arterioles. Again, going back to the morphology of the blood vessels of the arterioles, these are very rich in smooth muscles. Because of this, turbulent flow that's coming in through the major arteries hitting the arterioles can be converted into laminar flow. If we remember the term Reynolds number, which tells us the likelihood of flow being turbulent versus laminar, with the critical number being above 2000 more likely to be turbulent, flow in the aortic root has a Reynolds number of above 3000, while flow in the arterioles has a Reynolds number of 0.5. This is mainly achieved by those smooth muscles causing a major site of vasoconstriction, therefore leading to laminar flow past this point into the capillaries. So this is how the second caveat is semi-achieved. The third and final caveat of blood being non-Newtonian is negated by the property of blood displaying characteristics of apparent viscosity. What I mean by this is that we've already stated how if blood flow decreases, viscosity increases. However, flow is the slowest in the capillaries, followed by the arterioles, and then in the veins. So why does this slow flow in these areas not cause an increase in resistance and an increase in aggregation properties within these vessels? This is because as tube diameter is reduced below 300 micrometers, the apparent viscosity of blood is decreased. Arterioles have a diameter of 30 to 40 micrometers, so this is below the critical value of 300 micrometers. Therefore, apparent viscosity of blood changes because of two reasons. One, when shear rate increases, which we already know and makes logical sense, and secondly, when tube dimension decreases. Therefore, by having these three properties, the Windkessel effect, the use of arterioles, and the role of apparent viscosity with tube diameter, we can use the Purcell's equation despite it not meeting the three caveats needed. Hence, Purcell's equation can be rearranged to therefore explain how resistance to blood flow can be changed by the factors within the equation. The main factor that we already know of is going to be radius because it's to the power of 4. Now, putting this all together, we can start to see what are the factors that make blood pressure. Blood pressure is equal to the cardiac output times the peripheral vascular resistance. That's the most straightforward equation. Within this equation, each one of these factors has a subset of extra factors that affect it. So previously we've spoken that cardiac output is a product of heart rate times stroke volume. Stroke volume is a product of preload, afterload, and contractility. Peripheral vascular resistance is a product of Purcell's law, in which we say the main factors are the radius, the length, and the viscosity. And then there's a third factor, which is not in the equation, which is also determinant of blood pressure, and this is the total energy gradient of blood flow. This refers to all the things we're speaking about with regards to elastic energy, potential energy, kinetic energy, that connect back to effects such as the Windkessel effect. Now, before we move on and take a deeper look at total peripheral vascular resistance and the factors affecting it, another equation that can be shown to demonstrate blood pressure is to substitute blood pressure for MAP. Here we can say that MAP is equal to the cardiac output times the total peripheral resistance. Why do we use MAP, aka mean arterial pressure? Is that it gives the closest relationship to blood flow in tissues. Neither systolic or diastolic blood pressure is closely related to blood flow at this level. And then finally, and probably the most important reason why we love to talk about MAP, is that it is directly related to survival. MAPs below 65 are shown to be related to poor outcomes, and this is why many ICUs target this as their minimum MAP value that's acceptable in a critically unwell patient. So this moves us on to talking about total peripheral vascular resistance. We've already hit some of the key points, understanding that arterioles are referred to as the controllers of blood flow because they're the site which control the highest amount of resistance. The other key point that we've already established is that resistance is equal to Purcell's equation, where 8 times viscosity times the length of the tube divided by pi times radius to the power of 4 is equal to the resistance. And because the circuit length can't be changed, viscosity and radius are the most important factors affecting resistance. Out of these two, viscosity is the minor factor. It can be affected by hematocrit, the amount of proteins and lipid in blood, and the temperature of blood itself. Additionally, it can be affected by the tube diameter itself. Remember, that's what affects apparent viscosity. But really, the major factor is radius. At rest, we have ongoing sympathetic tone, which leads to a resting partial vasoconstriction state. And if we increase this sympathetic tone, we increase the constriction, thereby increasing total peripheral vascular resistance, and thereby increasing MAP. If we decrease the sympathetic tone, this will lead to vasodilation, leading to decreased total peripheral vascular resistance, leading to a decrease in MAP. So then looking more closely at other factors that can affect arteriolar tone, apart from just autonomic nervous system activity, we can divide this into local factors and then systemic factors. The two important local factors are local myogenic control and local metabolic control. Local myogenic control is also referred to as pressure autoregulation, and this concept is very simple. As the pressure rises, smooth muscle spontaneously contracts in the arterioles, keeping blood flow constant, and the opposite occurs with a pressure decrease. This ability of certain organs to autoregulate is especially important in areas such as the brain and the kidneys, where you don't want blood flow to change at all. The exact mechanism of action of why this occurs is still unknown, but it's thought to be related to either mechanosensitive ion channels causing a change in calcium influx and efflux. The second local factor being metabolic control, also known as metabolic autoregulation, is much more simpler to understand. This is simply a flow which is matched to the metabolic need. So if a regional area has an increased metabolic activity, it produces metabolic substrates such as CO2, hydrogen ions, potassium, adenosine, lactate, and a decrease in oxygen partial pressure tension. These all lead to smooth muscle relaxation and therefore a decrease in resistance, leading to an increase in flow to that regional site. Now there are other local factors, but these are more important to specific organs or specific areas in the body. Then in terms of systemic factors, we'll quickly rattle these off. We've already talked about extrinsic sympathetic nervous system activity affecting arterioles mainly through noradrenaline acting on alpha-1 receptors. Conversely, we also have extrinsic parasympathetic nervous system activity. This is less important in the regional circulation. Specifically in areas like heart, brain, and lung, you're really relying on the sympathetic activity either being increased or decreased to control regional circulation. In some other areas of the body, you do have the dual action of the parasympathetic and the sympathetic nervous system activity working, an example being external genitalia, where you get parasympathetic activity dilating and then sympathetic nervous system activity causing vasoconstriction. Then, apart from the autonomic nervous system alone, you also have the extrinsic factor of hormones that are circulating around the blood. These can be adrenaline, angiotensin II, antidiuretic hormone, or atrial natriuretic peptide, all causing a variety of effects from vasoconstriction to vasodilation. The last systemic factor is reflexes, and we'll talk about this much later. These reflexes involve the arterial baroreceptors, the chemoreceptor reflexes, the pulmonary baroreceptor reflex, and the effect of temperature, with heat causing vasodilation and cold causing vasoconstriction. So this sums up the first part of this colossal learning objective, covering understanding how systemic circulation works and the physics behind blood flow. Now, I'm not going to go on and discuss individual organ blood flow and autoregulation. So today, instead, being a podcast on regional circulation, What we'll look at is microcirculation and the control of this. Microcirculation refers to the smallest blood vessels in the body, being the arterioles, the meta-arterioles, the capillaries, and the small venules. We have already said that the capillaries' main role is essentially for nutrients and metabolic exchange. While the capillary network has a huge cross-sectional area, it actually only stores 6% of the total blood volume within the systemic circulation. The capillaries are made up of those thin endothelial cells with no media or adventitia. What's important to understand within the microcirculation is that at rest, only 25% of the capillary beds are actually open and patent. This means there's a large capacity and a huge reservoir to open up. The size of the capillaries is designed so specifically that it's only 5 to 10 micrometers in diameter. A normal red blood cell is approximately 7 micrometers in diameter. This means that any blood flowing through the capillaries is going to go super slowly at a rate of 0.5 millimeters per second. Not all capillaries are the same, and you can have different capillaries within the human body. The most abundant are continuous capillaries that are sandwiched between two layers of non-cellular matrix. Then you have fenestrated capillaries that you can see in areas such as the kidneys, and then you also have discontinuous capillaries that you'll see in areas where you really want a high turnover of exchange between nutrients and waste. The three methods by which fluids and solutes move across the capillary beds are said to be diffusion, filtration, and pinocytosis. Diffusion, which we've covered in the respiratory physiology topic, is the main way by which gases move. This obeys the fixed law of diffusion, and anything that's lipid soluble is more likely to diffuse across a cell membrane. Other things can also diffuse across, but there's a certain limitation to this dependent on the size of that molecule. So nutrients, metabolites, and water can all move via diffusion. Water-soluble substances diffuse across via intercellular clefts, as well as electrolytes such as sodium and chloride, and substances like glucose and urea can also diffuse across. The main limiting factor is that if a molecular weight of a substance is above 60,000 Daltons, it cannot pass. This means that albumin, which is 66,000 Daltons and has a negative charge, is not able to pass from the capillaries into the cell. But in areas of the body where the capillary structure is different, such as discontinuous capillaries, which have large gaps between them, like you see in the liver, albumin can go through. Therefore, knowing what type of capillary is present in each organ is important because it relates to the function of that organ itself. It would make no sense if the liver capillary beds were continuous and unable to exchange the albumin produced in the liver and push this into the capillaries itself. The second method of movement across the capillaries is filtration. This is sometimes also called bulk flow and is a really important concept to understand when it comes to regional circulation. What filtration describes is that there's two opposing forces that are pushing substances out of the capillaries and into the capillaries, and these forces are referred to as the Starling forces. The two forces are hydrostatic pressure and oncotic pressure. Each one of these forces has two components, the hydrostatic pressure within the capillaries and the hydrostatic pressure outside the capillaries. The same goes for oncotic pressure. This can be described as the oncotic pressure within the capillaries and outside the capillaries. If we put these four pressures into an equation, we get an equation which is known as the net filtration pressure equation. The net filtration pressure equation is equal to the sum of the capillary hydrostatic pressure minus the interstitial hydrostatic pressure, taken as one value, minus the sum of the plasma oncotic pressure minus the interstitial oncotic pressure times the reflection coefficient. The reflection coefficient is an adjustment made to account for the permeability of the capillary wall. i.e., if you did this equation in the liver where the capillary walls are discontinuous, the reflection coefficient would be 0. This means no substance would be rejected. In contrast, if you did this at another site where no solids would be able to pass, you would say that the reflection coefficient is equal to 1. So typically, if you were to draw out a capillary from the arterial end to the venous end, what you see is normally a gradient of hydrostatic pressure being higher at the arterial end and lower at the venous end, and then the reverse being true for oncotic pressure. Therefore, what we say is that hydrostatic pressure is the prime force moving fluid into the interstitial space, while plasma oncotic pressure is trying to retain those products within the capillary vessels, and therefore we say is the prime force opposing filtration. Normally, hydrostatic pressure tends to be slightly higher than the oncotic pressure, meaning that there's a small net loss of substances always going into the interstitial space. This is why the lymphatic system is so important, because it mops up any of those proteins or extra substances and returns them back into the systemic circulation. Clinically, if you either start to get disruption of that reabsorption system, being the lymphatic system, or you start to develop a high hydrostatic pressure, that's when you start to develop edema. Therefore, understanding filtration, the Starling forces, and the net filtration pressure gradient equation is really important to understand how much flow is filtered out of the capillaries and how much is reabsorbed into the capillary bed. We'll talk about this concept a lot more when we eventually get to renal physiology and looking at the regional circulation within the kidneys. Then finally, the last method by which fluid and solids move is penocytosis. This simply just refers to how large substances like proteins and albumin are taken across capillary walls by either endo or exocytosis through capillary endothelial cells. That is a very super easy concept to understand, and it completes our overview of microcirculation. This finally leads us to talking about our last section for today, which is looking at the control of the cardiovascular system. Whenever the word control is mentioned, you have to think about the control arc. This begins with the afferent input, sending signals to the control system, and then the control system actioning those effects through the effector part of this arc. When we broadly think about control in the cardiovascular system, the two ways we should look at it is short-term regulation and long-term regulation. Long-term regulation involves the process of renal handling, the balance of fluids and electrolytes, and that's a topic for when we get into renal physiology. Today we're going to focus on the short-term control, and these are the important responses that occur within minutes to hours to acute changes like changes in posture, exercise, stress, blood loss, that are really important to maintain that initial stability within the cardiovascular system. Now, before we look at the afferent inputs, because this is where majority of the information is, we'll first look at the control system. The main control system for the cardiovascular system is within the medulla itself. There is quite a complex relationship between the cortex, the hypothalamus, and the medulla, which all interplay with each other. The way I think about it is that afferent signals get sent by somatic and visceral receptors to the medulla via the nucleus tractus solitarius. The nucleus tractus solitarius is in the dorsomedial medulla, and it's the main place for receiving inputs, specifically from the glossopharyngeal and the vagus nerve. What the NTS does is that it has multiple interneurons. These connect up higher to the hypothalamus, but also to downstream efferent pathways. These interneurons can either activate these pathways or inhibit these pathways. For the sympathetic nervous system, the main connection from the NTS is to the rostral ventrolateral medulla. Think about this as the gateway to the sympathetic chain. The sympathetic chain extends from the thoracolumbar region from T1 to L2. It has short preganglionic fibers and long postganglionic fibers. The sympathetic chain has multiple effects throughout the body. At the same time, the NTS can also inhibit positive signals down the rostral ventrolateral medulla using another circuit called the central ventrolateral medulla. So if you activate the CVLM, what happens is a depressant effect of the sympathetic nervous system. Then, comparing this to the parasympathetic nervous system, this is much more simpler. The nucleus tractus solitarius has interneurons that connect to another nucleus called nucleus ambiguous. This is the main pathway that connects to the main parasympathetic nerve, which is the vagus nerve. Activation of this pathway will lead to all the parasympathetic effects on our body. So that, in a summary, is a very simple overview of how the control system works. There is complexities within the control system, and the main thing to realize is that there's multiple parts of the brain that can have an impact on the medulla. These range from the cerebellum, which can regulate CVS responses through joint and muscle activity. The midbrain and the pain pathways are closely linked to cardiovascular responses. The limbic system has a huge connection to the cardiovascular system associated with emotions. And then there's also the cortex and the hypothalamus that we've already mentioned previously. So now unpacking the meat of this control arc, which is really understanding the afferent pathway. We're not going to really focus on the efferent pathway because that's very self-explanatory. What you really have to know well is the afferent receptors and the afferent reflexes, because this is what examiners love to ask about. And the main receptor/reflex is the arterial baroreceptor reflex. These are arguably the most important for short-term blood pressure control. The arterial baroreceptors are located in two important positions. They're located in the aortic arch, in the transverse aorta, and then in the carotid sinus at the origin of the internal carotid artery. They are free spray-like nerve endings that are stretch mechanoreceptors. The afferent nerves carrying their signal include the glossopharyngeal nerve from the carotid and the vagus nerve for the aortic receptors. These receptors are called a reflex arc because they lead to a negative feedback loop. The classic loop starts with an increase in blood pressure. That increase in blood pressure causes an increased stretch in the wall of the aorta and the carotid vessels. This is sensed by the mechanoreceptors, which now have an increase in action potential discharge. That increase in firing rate is relayed up to the medulla via the nucleus tractus solitarius. Here, the goal of the control system is to decrease the sympathetic response to bring blood pressure back down. So to do this, it needs to decrease the activity of the rostral ventrolateral medulla, so the RVLM needs to be decreased. The way it does this is through activation of the CVLM. This leads to the RVLM being depressed and the sympathetic activity being decreased throughout the body. Additionally, in this loop, there's thought to be increased activity to the nucleus ambiguus, increasing the activity of the parasympathetic system. The net end result is a decrease in heart rate, a decrease in contractility, and a decrease in vessel tone. All of these lead to a decrease in stretch through those main arteries, and therefore the free spray nerve endings have a decrease in action potential firing rate. That is the classic arterial baroreceptor reflex. However, when we commonly talk about it, we always talk about it in the opposite situation, which is when there's a low blood pressure. With this, we get a decreased stretch of the carotid and the aortic vessels, a decreased firing rate of the nerves, so therefore decreased signals going up to the nucleus tractus solitarius. Now all of a sudden, the inhibitory pathways acting on the RVLM are no longer there, and the sympathetic system is allowed to be activated, leading to an increase in heart rate, increase in contractility, and an overall increase in blood pressure. The other side note thing to understand about the baroreceptors that you might be asked as a bonus question on the Viva is that they respond to not only absolute stretch, but they also respond to the rate of change of stretch. In clinical terms, what this means is that they respond both to MAP and pulse pressure. And between these two, the effects of changes in pulsatile pressure has a bigger effect on changing the firing rate of baroreceptors. You can also plot out the baroreceptor firing rate on the y-axis compared with the x-axis, which is the mean arterial pressure. If you do this, and there's a diagram in Papano which shows this, what you'll notice is that it has the same sigmoid shape as the oxygen dissociation curve. The significance of that is that it has that steep portion in the middle where small changes in MAP lead to a huge change in the baroreceptor firing rate. The other important thing about this curve is that it can also shift with age, and therefore change where that middle zone sits. Now, if you understand all that about the arterial baroreceptors, you are definitely safe in any Viva setting. The important thing to recognize, and sometimes gets misunderstood, is that arterial baroreceptors are just one type of baroreceptors within the body. There are also other types of baroreceptors that all kind of get clumped into one, but they're actually quite separate. So within the cardiovascular system, there's also cardiopulmonary baroreceptors, which are referred to as low pressure baroreceptors. These include the venoatrial stretch receptors, that are low pressure receptors located in the endocardium at the junction of the vena cava and the aorta and the junction of the pulmonary veins and the atria. The information they provide to the control system is information about the CVP and cardiac distension. And these are really important in controlling blood volume because the net effect of these can be a change in the amount of ADH released and the amount of ANP released. Then there are also other types of baroreceptors called cardiac mechanoreceptors. These are located mainly in the ventricle, and they also send information to the control system about the stretch of the ventricle. These receptors are specifically important in the basal gyrus reflex, which took me forever to understand, but it's as simple as a fast, underfilled heart leads to an increase in vagal tone. That increase in vagal tone can lead to a sudden cardiovascular collapse. The classic example of this is someone that's having a spinal who's in labor. Now going back to the other afferent receptors to complete this learning objective, we've mentioned the baroreceptors, both high pressure and low pressure, but there are other receptors that are also important and contributing to the control of the cardiovascular system. To quickly run through these involve the peripheral chemoreceptors. So the chemoreceptors that we talked about in our respiratory physiology topic are closely linked to the arterial baroreceptors. When those chemoreceptors get activated, increased impulses from the aortic and carotid bodies stimulate vasoconstriction, increasing blood pressure. This makes sense when you think about it because you want increased blood flow going through the lungs so you can optimize gas exchange. Other receptors to mention are pain receptors. This is classic. Whenever there's pain, there's typically a sympathetic response leading to a tachycardia and hypertension. Another receptor is temperature. Classically, cold causes vasoconstriction and warm causes vasodilation. And then you have less familiar reflexes completing the afferent circuit. So these reflexes are the diving response and the pulmonary stretch response. That brings us to the end of a very, very heavy learning objective, which in my experience, for the amount of content we've covered, doesn't translate to the same amount of SAQs in the past exams that have been asked by ANSCA or in the KICM exam. So really, to finish off, there's 3 SAQs that I want to have a quick look at before we finish today's pod. The first is the most likely to come up and was last asked in 2022's second sitting, which was briefly outline the difference between the pulmonary circulation and the systemic circulation. This had been asked previously in 2015 and both times had a pass rate around 50%. In the latest examiner report, the main domains assessed were anatomy, hemodynamic variables, blood flow distributions, vascular resistance, and function. The way I thought about this question when thinking of a model answer is probably having a table structure with those headings mentioned in the examiner report. The key here is to also recognize the wording of this question, which is briefly outlined the differences. So my model answer actually has 4 headings to it, just to simplify it. Anatomy, being that the systemic circulation is a circuit from the left atrium to the right ventricle, and in contrast, the pulmonary circulation is from the right ventricle to the left atrium. The main difference in vessels is that the systemic circulation has thick vessels because of the high pressure system, while the pulmonary circulation has thin-walled vessels that allow for its main function of distensibility. Both circulation systems are innervated by the sympathetic and parasympathetic nervous system, while the pulmonary circulation certainly has a lot less parasympathetic innervation. The important thing to realize and state to show understanding is that both systems take on the full cardiac output. And this means they need to be able to cope with major changes in volume. The second heading I have is functions. The main function of the systemic circulation is to deliver oxygen and remove waste products. The main function of the pulmonary circulation is to oxygenate blood, be a reservoir for CO2, allow for filtration, have immune function, and have its own minor metabolic function. Then my next heading is hemodynamics, and here you involve what the normal blood pressures are in each system, the resistance in each system, and I classically use Wood units because it's just easier to remember. So the pulmonary circulation is 1 to 2 Wood units, while the systemic circulation is 10 to 20 Wood units. The key words you want to state here is that the systemic circulation is both high pressure and high resistance, while the pulmonary circulation is low pressure and low resistance. This means clinically the pulmonary circulation is affected more by hydrostatic forces, and this is why we have the division of the West zones within the pulmonary circulation. While really the systemic circulation maintains its high output and pressure until you get to the arterioles, where you want the slowing down of flow to allow exchange to occur within the capillary beds. Then the last heading I have is regulation, because I think that's quite important when comparing these two systems. When thinking about the regulation of the systemic circulation, you can think about the factors of regulation as those that are local and systemic. So going back to the local, myogenic and metabolic factors, and then the systemic factors being the sympathetic and parasympathetic tone, the circulating hormones such as adrenaline, noradrenaline, the effect of other hormones like antidiuretic hormones, angiotensin, and in comparison with the pulmonary circulation, the main factors that affect blood flow are going to be hypoxia, CO2, temperature, and pH. And then uniquely in the pulmonary circulation, what's also going to affect its flow is the lung volume itself. That is my summary for this SAQ. The next question I want to cover was kind of from left field and asked in 2012, which was outline the important features of the lymphatic circulation. This is a very Ansgar-like question because you don't think of this topic as the first thing you think about when covering regional circulation. What I will say is that when this question was asked, the pass rate was 10%. So I would say that it's a very fair game for this question to be asked again. And the examiner report was actually very helpful. It said that you could structure this question with the following headings: structure and anatomy, composition, principal functions, and a brief overview of factors that would see an increase in lymph formation. And really, I would just follow this examiner report when trying to make a model answer, and Propofol Dreams has a perfect answer laid out with those headings. The structure and anatomy being that the lymphatic capillaries are present in almost all tissues except cartilage, bone marrow, and the CNS. The flow is driven by intrinsic factors such as the smooth muscles in the wall, and extrinsic factors like the external pressure of muscular contraction. The flow is unidirectional due to valves, and the lymph vessels travel alongside the arteries and veins. Majority of the lymph is returned by the thoracic duct, which drains into the circulation by the junction of the left subclavian and the internal jugular vein, and then a minor portion is returned by the right lymphatic duct. The composition of lymphatic circulation is lymph itself, which is interstitial fluid that enters the lymphatic circulation. Again, this relates back to those Starling forces that we spoke about. Proteins, coagulation factors, fat, lymphocytes, giving it its name and its color. And all in all, there's approximately 3 liters of lymph produced each day. The main functions of the lymphatic system is to return the proteins that are lost back into the systemic circulation, transport fat, with 90% of fat that's absorbed through the gut has to go through the interstitial fluid and then enter the systemic circulation. Lymph also has an immunological role, and that's obvious because lymph nodes become raised when you're sick. And then the other function of lymphatic circulation is that it can help to make concentrated urine by removing that protein-rich interstitial fluid, thus allowing the maintenance of an osmotic gradient. Finally, for bonus marks, you can put in the factors that would increase lymph formation, being exercise, peristalsis, or elevated capillary filtration, relating back again to the Starling forces. The last question I want to look at is from 2015, which was describe the role of baroreceptors in the control of systemic arterial pressure. This question also had a 50% pass rate, and the examiner report stated that good marks contain information about high pressure baroreceptors and their location, how mechanoreceptor firing pattern changes with arterial blood pressure, the neural pathways to the central nervous system, and a summary of how central integration occurs, modulating both the sympathetic and parasympathetic outflow tracts. In this examiner report, they did also mention that low pressure baroreceptors was needed to complete the answer, and that a mention of how these tend to have a longer effect on maintaining blood pressure by affecting hormones controlling the intravascular volume via the kidney. I think the best model answer for this question is the ketamine nightmares answer. The first time you look at it, you kind of get overwhelmed because there's just so much information to take in. But if you break it down to what we've spoken about today, which is that you have high pressure baroreceptors, being the classical arterial baroreceptors, so the ones in the carotid and the aorta, and these go through the arc which involves the medulla starting at the nucleus tractus solitarius, and then the positive side, which is the rostral ventral lateral medulla, controlling the sympathetic output, and the CVLM providing the inhibitory pathway to that sympathetic output. Then you have the nucleus ambiguous, allowing the parasympathetic activity to flow through the vagus nerve, and that normally an activation of the baroreceptors occurs when a blood pressure is high, leading to an increased stretch detected by those free spray nerve endings that are mechanoreceptors. The one thing I forgot to mention is that the baroreceptor arc also has some additional effects, not just only on the parasympathetic and sympathetic nervous system. These involve changing the activity of ADH and altering the activity of ANP. Then the low pressure baroreceptors, which we've said are in the atria, the great veins, and also in the ventricles, are mainly there to regulate blood volume on the longer term basis. These really rely heavily on manipulating ADH and ANP, and ANP is a really important hormone to know about. If you increase ANP activity, you increase the dilation of afferent arterioles, thereby increasing GFR, so now you get more flow through the kidney, leading to increase in natriuresis and an increase in urine output. Subsequently, what that does is it decreases blood volume and it decreases CVP. So if you remember that pathway, what you'll know is that if an atria or a ventricle is stretching, typically what's being released is ANP to help decrease the blood volume to decrease that stretch in either the atria or the ventricle. That's why BNP, which is just another form of a natriuretic peptide, is a good biochemical marker we use to see if a patient is in heart failure. And this hormone is going to become even more important now because we have specific drugs like sacubitril that inhibit neprilysin, which is the enzyme that breaks down ANP. Now all of a sudden we have an increase in ANP, and we have new agents called ARNIs, which are changing the way that we treat heart failure. That will do it for me today, guys. We've covered some very heavy learning objectives, and while they might not have as many SAQs as other topics we've covered, they certainly are important to know in the broad sense of cardiac physiology. Next time I'll be back for the most SAQ heavy topic for cardiac physiology, which is applied cardiovascular physiology. That is going to be another huge podcast, but it goes without saying, anything that has applied in it is really an examiner's favorite topic. So until then guys, good luck with your studying, and I'll catch you next time on Count to 10.